We are live now, ma'am.
Thank you, Purnima. We will start sharp at 3. Okay, so a warm welcome to everyone present here. Okay, I started the recording. So a warm welcome to everyone present here on behalf of Team OATN.
Thank you.
Just, thank you, sir. Thank you, Guruji. Just a quick housekeeping announcement before we begin the meeting. We request everyone to keep your mics on mute, and if you have any questions at the end for the panel members, then we will take up your questions. So as we put in the chat box, the meeting is also live on our YouTube channel. So with this, I'm going to start with the formal welcome address that I have for the day. So if you can all see my screen in here. So we welcome you all to this panel on the future of geriatric eye care. And of course, we must have heard this hundreds of times by now, which is the World Report on Vision's note saying that 80% of people who have a bilateral visual impairment, 2/3 of this population belongs to the age group of 50 years and above. So what is our role as optometrists? And when we really look at the agenda for the Sustainable Development Goals by the WHO, goal number 3 and goal number 10 talks about ensuring healthy lives and promoting well-being for all ages and also reducing inequality within and among countries. So this is a statement from the United Nations, future, like overall when it talks about the Sustainable Development Goals and the future challenges of India's aging population that you see here, which just keeps rising as when we look at by 2050, the population age 60 plus is quite a number. And I would just like to point all your attention to this one statement, which was quite, I felt is important for us to note, which is older persons must be recognized as the active agents of societal development in order to achieve truly transformative, inclusive, and sustainable development outcomes. So not only that we have people who are elderly at home, but that a vast majority of our population, including all of us, are also on the aging spectrum. And what is really like heartbreaking is that in India, 43% of the aging population earns nothing at all. And so today we have so now that there is this huge problem statement in front of us, and we also have we also foresee the challenges. Of course there must be solutions, but are these solutions achievable? And how do we ensure, as primary eye care practitioners, how do we ensure that we provide the best of our care to this population that deserves its care? So the lineup of speakers, as you see here, starts from Padma Shri Dr. V.S. Natarajan. So I'll be introducing him shortly, who is the chief guest for our day. But he is an octogenarian himself, and a couple of days before, he just called me up and told that this heat is quite intolerable for him, and on a Sunday he needs to really make sure that he gets supportive systems in place to go live on Zoom for this particular session. So realizing the challenges associated with the geriatric population in itself, we as a team decided that let's not really burden him, and let's just get a recording for the session, because his heart is very much in here, and maybe he's just watching this on YouTube live as well. So we've got a recording in the place of his live chief guest address, which he has beautifully prepared. One request is that please use headphones when you want to listen to this recording. And the next lineup of speakers include optometry experts with public health expertise, who is dealing with these challenges that we just discussed about. How do we meet the unmet eye care needs of the geriatric population? So we have Dr. Lisa Key, the head of school at the School of Optometry and Vision Science at the UNSW Sydney, Dr. Srinivas Varmamula, our familiar faces in India, Dr. Vijay Kumari Gothwal, and Dr. B. Harishankar, who is direct student of Dr. Padma Shri, Dr. Natarajan sir himself. So being a geriatric physician, he will be able to offer the wisdom that he learned from sir, plus his own expertise over the last decade. And last but not the least, we have Guruji Sannyasi Krishna Yogam sir with us, a disciple of Swami Niranjananda. And so Guruji is specialized in yoga. So we have our esteemed team who will be introducing our panel members as their turn comes in. But this is the great lineup of speakers that we have for today. And this is the welcome address that as I'm delivering, I'm just going to also be playing the chief guest address on behalf of Sri Dr. V.S. Natarajan. And then we will just proceed with the session. So Padma Shri Dr. V.S. Natarajan, as you see here, so he just looks the same as he looked in his 50s, though as I just told, he's an octogenarian himself. And sir possesses an MD, and he has his the esteemed FRCP and from the UK, and he's also been awarded a honorary PhD from the MJ Medical University. So of course his accolades are like too vast, but some of the key points from his long list of accomplishments, which are very relevant for today, is that he is the pioneer in establishing an outpatient wing in geriatric medicine in MMC, Madras Medical College, in 1978. And it is the very first unit in the whole of India. And then it started with 10 beds. And so he's the first person in India to be appointed as the professor of geriatric medicine of Madras Medical College, no doubts. And so he went ahead and founded the Dr. V.S. Natarajan's Geriatric Foundation, the very first medico-social foundation exclusively for elder care, inaugurated in 2017. And it involves in various activities and collaborations, which I will just list out. And some of the most important activities that are being done as part of the passionate activities that Dr. Natarajan is involved in includes establishing a memory clinic, especially to nurture mental health. Like in a country like India, like issues like mental health are given the least priority in many other countries as well, now that we are starting to speak about this topic. The next is the famous Geriatric House Call Project, which is a novel method of treating elderly sick patients at their own residences. And I've known few beneficiaries like who have benefited through this wonderful project. And he has ventured into preventive geriatrics. So when I visited his foundation, I saw this geriatric immunization center, And he's the first person to start this immunization center, stressing the importance of the need for prevention to always lie ahead of cure. And of course, among the many awards, he holds the Padma Shri Award in the year 2012 for rendering service in the healthcare of aged for more than 3 decades. And of course, this is nothing for what Sir has done. So the campaigns, the 3 campaigns that he is very passionate about, apart from the falls awareness and prevention campaign and the adult vaccination awareness campaign, the one campaign that has reached the government itself is the campaign on let us respect elders pledge, like very, very important, like having lots of joint communities and families. So because of all the efforts of Dr. Natarajan, a government order was passed by the Department of School Education that every year on the 15th of June, on the event of World Elder Abuse Awareness Day, all the government school children in Tamil Nadu would take a vow saying that let us respect our elders at their assemblies. And so on in 2017, when this was started, almost about 100,000 government school students have taken up this pledge. So of course, this is really wonderful, right? So this is his chief guest address. So as I just requested, please use headphones to listen to his address, a very short address, where he just enumerates about some of the common eye problems in the elderly and the role of optometrists, in being able to alleviate these problems. Okay, so I think 1 second, I'm just going to change the audio settings because Gopi, just tell me if this is audible. 1 second.
Audible, yeah.
Thank you.
So the elders are very keen in the elders of then also so we have police. Even if we remember what the other day said, the next like post one year was point. So there are many reasons for it not age also that had the own government because glaucoma normally we have to be British actually care very important. We educate the elderly people the importance of right. And afterwards, those were speaking of the talk about the care of the important. These are the then we can also source media, separate tablets and other media as their like the other important principle is the vaccine program master. The program master. That you can see everything there, but they're not even after the test. So mandatory to be important. Every imagine positive they must include some optometry in the hospital. Very, very important. Third, we prepare setting, not your certain issues. Certainly, the upper season, small drops, and these are very important points. Awareness of the entire area, awareness is very as to the campus. Thank you very much.
Okay, so he just enumerated about the common eye problems that are seen in the elderly, and he just reiterated the whole world report on vision statement, saying that optometrists need to be an integral part of every master health checkup that elderly takes as part of their general medical health checkup. So that's what he was just reiterating, and he was also talking about some of the other socio-economic issues that are preventing these elderly from seeking eye care when they need it. Okay, so I would just like to end this welcome address with just this one note, because as I was just preparing for this today morning, my 73-year-old father-in-law had stroke symptoms and he's been hospitalized, and so he's just living alone, and I couldn't just rush because we're living very far off. And so this is how the current support system for elderly is. But thank God we've got a very good community that has taken care of them and provided with all the required medical support. But this is not a recent one. This is almost like 7 years back, where where almost 15 million elderly Indians live alone. And so this is the lonely world of this elderly population. And so what is our role as primary eye care practitioners to make sure that the unmet eye care needs are being taken care? So with this, I now request our Vice President, Mrs. Preeta Ramprasad, to introduce our first speaker for the day. Over to you, Preeta.
Thank you, Rusmana. So good afternoon, everybody. I welcome you all once again for this panel discussion organized by OATN on the theme Eye Care for All to mark World Optometry Day celebrations. We have several subject experts lined up to talk about the future of geriatric eye care. I feel privileged to introduce the first speaker for today, Professor Dr. Lisa Key. Dr. Lisa Key is the head of school at the School of Optometry and Vision Science. Just a second. UNSW Sydney, and she's also an honorary professional fellow at the George Institute for Global Health, UNSW Sydney. She's a public health researcher with expertise in epidemiology, health promotion, and injury prevention. She trained as an optometrist. She has a PhD and MPH from UNSW Sydney, and she also completed a research fellowship at the Dana Center for Preventive Ophthalmology, Johns Hopkins University. Her research activities focus on patient-centered healthcare, rehabilitation, and the prevention of injury in older people with vision impairment. She has a program of research in safe mobility for older drivers. Considering links between cataract-related vision loss and falls risk, she is also generating evidence for benefits of timely provision of cataract surgery. She is leading and also investigating a novel program for preventing falls for older people with low vision in a large-scale randomized trial. Her health systems research includes evaluation of new models of care for chronic eye diseases in Australia and refractive error correction in low-income settings. She has authored several book chapters and peer-reviewed journal articles. With that, I welcome Dr. Lisa Key to talk about falls among the elderly, prevention and intervention. Over to you, ma'am. Thank you so much for this opportunity.
Thank you very much for the introduction. It's a great opportunity to be here and to join you from all the way from Australia. It's been a really tough time not being able to travel. I've enjoyed many visits to India and I'm looking forward to coming back in the future. I'll just share my screen now. Let me know if that's coming up now.
Yes.
Great. Okay, so it's a great lineup today. I'm really happy to be talking about this. It's something that I feel very passionate about, and I've done quite a lot of work looking at the broader implications of vision loss and how our eyes affect other parts of our health, and falls is certainly one of the really important areas. Okay, so I've got some data on a graph here, and this data is actually from the Million Deaths study from India. One of my previous PhD students, Dr. Jagnor, did some analyses on this data, and she looked at injury-related deaths. And you can see on the graph that there's the major types of injuries that cause death in India and other parts of the world are drowning, road traffic injuries, and falls. And the important point to note from the falls is that we get a few falls in childhood. We get some falls in working age. There might be more falls from height, work-related injuries, but geriatric falls are exponential. So you can see that that rate of falls really is escalating when we get into the later decades of life. So injury is a major cause of death and also disability. And we know that 70% of fall-related deaths occur in low and middle income countries. And that sounds very familiar to us talking about the World Report on Vision, where we know that vision loss is disproportionately affecting people in low and middle income countries. We also know that falls as a cause of death is increasing, and that is related to population growth and also population aging. And we've done, with my colleagues who I've worked with in India at the George Institute for Global Health, we've done a few small studies looking particularly at falls in older people in India. And one of the studies that Dr. Jagnor led was a qualitative study. And I put in a nice quote here from an older person who was in one of our focus groups. And they're saying, we try our best not to hurt ourselves by fall, but at times we're just helpless. Age makes you weak, you lose balance, limbs feel cold and numb and dizzy. So these are falls are a familiar problem. I think many of the people here on this webinar will know relatives who've had falls, and it's really set them back. It's the direct injury cost, and it's also the chance that you feel very nervous and frightened that you might fall again. We also noted when we talked with people, it's hard to engage with people about falls prevention. They know about falls, they know it's something they want to avoid and that it can cause major problems, but they've got other things on their mind as well. There's other health priorities. There's chronic diseases that become more and more common in older age, and concerns about meeting medications. So it's a challenging area. We know this is a really big burden, but we also know that it's hard to engage with older people and help them understand that we can prevent falls and there's steps that we can take. So I really like this picture, and I've taken it from a nice publication in The Lancet, and it's actually some video analysis looking at people who have had a fall in an aged care facility or a nursing home. And I'm looking very much forward to hearing Srinivas's discussion about his research in aged care homes in India. But what this shows very nicely is that when people fall, you can really see that they're losing their balance. So here's somebody who has a walker and they're falling over. Other times you can see there's a distraction. Maybe this is a very nice lady he's seen here, but there's also a dog in the picture and he eventually falls and just a misstep. The other one, similarly, even the bottom picture, you can see someone can have a fall even when they're just trying to get out of their chair, if they really don't have the strength and the balance in their lower limbs. So this is what we're talking about when we talk about geriatric falls. They're falls from the same level, not from height, not work-related construction sites. It's very much tripping and slipping and losing their balance. And we know that falls are a complex syndrome, if you like, and there's multiple risk factors. So there's behavioural risk factors, for example, taking a lot of different medications, which is common in older age, excessive alcohol intake, lack of exercise, inappropriate footwear. There's biological risk factors as well, and that's what we've already been talking about, that people are complex and have multiple morbidities. There's also cognitive decline. Amongst the biological risk factors is vision loss as well. There's also other factors, socioeconomic risk factors and environmental risk factors. So what is the home environment like? Are there loose rugs? Are there slippery floors? So all of these things combine in a perfect storm to increase the risk of falls. So it's a complex and very interesting area to be doing research. But we know from a very large volume of research that vision is an independent risk factor for falls. So there's some data here that I've summarized on this slide, and I've listed many different studies here, very strong, large, longitudinal studies, which have shown that if you have vision impairment, you increase your risk of falls, particularly recurrent falls, which is really where people are having this as a repeat problem and really not just bad luck, they're really inclined to fall. So there's a bunch of studies here, and some of the studies have looked at specific types of vision loss, so visual field loss, particularly the peripheral lower visual field is particularly increasing your risk, but also central field loss. And we know that there's particular conditions that have been associated with increased falls risk. And this picture on the right just shows what your normal vision could be like, and then what it's like trying to see the edges of stairs if you have decreased contrast sensitivity with cataracts and some field loss in glaucoma. So some very clear data that shows vision is absolutely critically important to seeing obstacles, and also to, it's a impact on other aspects of health. So if you have poor vision, you've also often got poor general health, low physical activity. So it's a little bit of a vicious circle as well as a direct impact. Okay, and there has been a really nice study done decades ago now, but in the UK, they showed very eloquently with a randomized controlled trial that if you get people to have surgery in a more efficient way, so getting their first eye surgery done within 4 weeks compared to the other randomized group who were waiting about a year for their surgery, you can reduce the falls rate. And it's pretty significantly reduced by about 1/3, and even higher for the recurrent fallers. The graph I've shown on this slide shows that the big difference between the expedited surgery group compared to routine surgery. So that's quite nice. Not only do we know that the vision loss influences falls, but we know that cataract can prevent falls if we get timely access to surgery. So we've looked at this in Australia, and even in a high-income, wealthy country like Australia, we still don't have equitable access to cataract surgery. We have a dual system where there's free public surgery, and there's also paid out-of-pocket cost surgery. But what this graph shows that up to a 7-fold difference in the rate of cataract surgery in different parts of our metropolitan area, and this is focused around Sydney, where the north is quite affluent and the southwest is a lower socioeconomic area. So you can really see that things do get quite inequitable if we're not mindful and really focusing on our service delivery. And that's been identified in this Atlas of Healthcare Variation. Our federal government has identified this as a priority area. And we actually did a large study. It was an observational study looking at people while they were waiting for cataract surgery. So people joined very long waiting lists to get the free surgery. And we also looked, had quite a lot of detailed information, which is relevant to optometry, about exactly what spectacles people were wearing, what their vision was like, and all the other many risk factors that we know about for falls. And this is a study design. We had a pre-surgery period, a period of time between first and second eye surgery, and a post-surgery period. When we do falls studies, we use a calendar, get people to send in when they have a fall. We ring them as well to make sure we get complete information. So that's the gold standard way to detect all of the falls during the study. And we had lots of different measures of vision, including what sort of spectacles they're wearing, which was of particular interest, and how often they're moving about, what their level of physical activity is. So the most compelling result here is that the absolute rate of falls was the highest before they'd had cataract surgery done. So these are people with cataract, and their falls rate's about 1.2 falls per year. So almost everyone's having at least one fall. After first eye surgery, that group had lower falls rate, but after second eye, it's particularly low. But what you find here is that when you limit the data set to just the people who went through the whole cataract surgery journey, really the benefits is after both eyes are operated. And I think that makes sense to all of us as optometrists, because we know that people haven't really got their fully restored binocular vision function until they've had both eyes operated and they've got resolved their anisometropia and all those other tricky problems which come with just having one eye operated. And then if we want to look at the actual numbers, so we actually age and sex adjusted for all of the other factors that we collected in a detailed manner here. And the important points to note, I've pointed out these incidence rates that are adjusted incidence rates is here. And you can see that the post-operative rate is much lower, and we're having the incident rate ratio is a substantial reduction. So a 50% reduction from that between two surgeries to after having both surgeries done. It was very interesting to have a look at spectacle correction, and this is really topical because a number of research studies have looked at spectacle correction and how this impacts falls risk. And what we found was quite complementary to the many laboratory studies done around the world by experts such as Professor Dave Elliott in the UK. And we found that there was about a double increased risk of falls when people had a large change to their spectacles. So if they have a change of 0.75 diopters or more, they were at increased risk. So we could hypothesize that people were used to a certain level of magnification, and when they get a new pair of glasses, they're already at risk of falls, and then this can and make things more complex, and they've got a higher rate of falls. And I put in a little bit of data from a randomized controlled trial, which looked at, in this study, they aimed to rehabilitate the vision through many different ways. What they actually ended up doing in about a third of the cases was prescribing new glasses. Fewer had other sorts of surgical intervention and medical intervention, but inadvertently, they increased the risk of falls. So this was in a study that was meant to prevent falls, but they inadvertently increased. So it does seem that spectacles are a very important part of falls risk management. We have to prescribe very carefully for older people who are at risk of falls. So from this research and from my group and other groups around the world, we know that timely access to cataract surgery is really important. So people will see clearly, they have good contrast sensitivity, they can identify hazards, they can maintain their physical activity and maintain their health. We, of course, want to diagnose and manage other eye conditions, but we also want to manage spectacle correction very carefully. So be cautious about changes and also moving between different modalities. There's some question about having people in high addition or in multifocal spectacles, for example. So if they're active and outdoors a lot, they could wear single vision lenses perhaps. The evidence is actually from single vision tinted lenses, but that's really only one study. But I think it's absolutely critical that when we're prescribing glasses, we're thinking about falls risk to make sure we look after people. But I also want to propose that we could do more as optometrists. We could ask them about their risk of falls. So one of the, I've just put in some pictures here from the US, from the Center for Disease Control, which has a program which is designed for healthcare workers so that they can identify people at risk of falls and refer them to appropriate care. So you can't see it here, but it's a simple checklist, and there's many checklists. And it's really, at the very least, it would be good to ask people if they've had a fall, because that's predictive of another fall in the future. But you can ask them about all the other factors. You can do some measurements. And then this is the STEADY program in the US. It's proposed that you could refer people to a specialist who could prescribe falls prevention or other recommendations. Maybe they could see a podiatrist about their feet, or they could see, obviously you could look after their vision, but there could be other factors that could be, you could do things to help people stay on their feet and stay healthy for longer. And I was really excited to talk about this very small study that I was a part of, particularly considering that there's yoga is on the program later this evening. And with my colleague, Dr. Praveen from the George Institute in Hyderabad, we did a very small study. It was just a pilot study involving 50 older people who were resident in an urban area in Hyderabad. And we invited them to participate in yoga. And it was early in the morning every day for a period of 3 months. We did some measurements of their physical performance before and after doing the yoga program, and we found some really good improvements. So they were better at getting in and out of their chair in that timed 5 times sit to stand. They walked more efficiently with better stride, so they had less steps in their timed 4-meter walk. And they also were very happy that they had a bit of weight loss. So it really got people exercising. We did some interviews with the people who participated and some focus groups, and a lot of the positivity was about yoga being a holistic and a preferred exercise regime, obviously very popular in India. One of my colleagues in Australia has a really large study evaluating yoga as a falls prevention program. There's many different types of exercise that can prevent falls, but the main thing is to challenge strength and balance. So the type of yoga that we did in this program was all the standing poses to improve that. So that was a nice aside and a nice little research study that I got to be part of. So in summary, falls are common in older age and a major cause of injury. They also cause people to feel very nervous, and they might not want to go out and be healthy and stay engaged in their communities. In Australia, about 1 in 3 persons over 65 fall every year. And obviously it's a major cause of hospitalizations, particularly hip fractures. We know that falls are common in older age, multifactorial in their nature, but vision loss is an independent risk factor, so we absolutely can contribute to falls prevention. We know there's inequities in access to cataract surgery, and there's also inequities in the prevalence of vision loss in different socioeconomic groups in Australia and also India and all over the world. So we really need to make sure people's vision is well looked after so that we can keep people healthy and happy in their older age. We need to be very careful with spectacle prescribing. We've done a bit more work on that recently, looking at what the evidence is in the literature and how that can work in practice. There's lots of challenges for implementing evidence into practice, and we've looked quite carefully at the logistics. And I think it's a great opportunity for optometrists to work with other health professionals, particularly because some falls prevention programs like changing medications for general health conditions is going to involve other practitioners. We're not going to be doing this on our own. So thank you very much for the opportunity to present. I hope it's been clear all the way from here on the coast of New South Wales in Australia, and I'll wrap up there. So thanks very much.
Yeah, thank you, Dr. Lisa K. I'm Gopinath, and I'll be taking over the moderating the session, and I thank Dr. Rizwan and OATN for providing this opportunity. Thank you, Dr. Lisa, for emphasizing the role of optometrists and the importance of proper spectacle correction, timely cataract referral, and surgical intervention and other intervention methods to reduce the falls among elderly. And do we have any questions in chat box? I think over in Zoom, I don't see any questions. Please, participants, if you have any questions, keep posting it. We might take it later as well. So
there's one question about the long wait for cataract surgery. It's very embarrassing that Australia has a problem with delivering cataract surgery to all of its citizens. This is not just unique to Australia, Canada, The UK, less so. They've actually put some resources into it. But a lot of national health systems do have long waits when they consider something to be elective. So our health system is very good. It's a great health system. We do very, very well in acute care. But when something can be delayed, we do occasionally get very long delays. And there's other surgeries that could be the priority. So unfortunately, we do get unacceptably long delays. And we're trying to make a business case for government. And we believe that it will save them money if they do the surgeries earlier, because they won't have to treat the hip fractures. And we've made that economic argument, just trying very hard to get that change and get those surgeries moving through the public hospital system.
We have another question from Dr. Krishna Kumar. Whether what is the call on prescribing bifocals versus progressive addition lenses among elderly?
Yeah, so there's a few different pieces of research that have looked at the impact of spectacles, and the really nice work comes out of Dave Elliott's lab in the UK, and he's really looked at this in quite a lot of detail, and he believes that it's the magnification effects. So if you're habituated to a certain magnification and it changes, that's when you're going to have inappropriate step clearance, for example, and put yourself at risk of a trip. He could talk much better about it, but that's the take home that I've taken away from his message. And what we found is that people had these quite large changes in their spectacles after they've had cataract surgery. So that's really common, isn't it? Because often the cataract surgery addresses the emmetropia. And we took the cut point of 0.75 because that had been proposed in other research studies. So we investigated that in our regression analysis, and we found that it was significant at a 2 times increased risk. It's going to vary individual to individual, and there is research that looks particularly at bifocals, and one study did propose deprescribing multifocals, and they found a bit of a patchy result. They had benefits, but only for the people who walked outside a lot. So for people who were inside and not really active outdoors, they didn't get the benefit. In fact, they had a little bit of an increased risk with their change of their glasses. So I think the jury's out a little bit on whether multifocals or bifocals are a problem in and of themselves. I think they have such great benefits, particularly for the convenience of one pair of glasses. So I think there's always a bit of challenge in implementing research into practice. And some of the suggestions we've heard from practitioners when we've done some consultation in Australia is using a trial frame and testing if people can feel comfortable and mobile with slight changes, and only making a change that they really feel comfortable with, demonstrating what the multifocals are like, if you can, with a demonstration lens over the top, if you get some from a lab. But it's a complicated area, but I think that education involving the patient in their changes to their glasses and making sure they're cautious could also be some help. So I hope that's not too long a response. It's just a difficult question, that one. Very interesting.
We have a last question from Ramya. Whether comprehensive any exercise programs reduce falls in people with poor vision, which cannot be corrected by any means.
Yeah.
So if yes,
yeah,
what
so that's a great question, and we actually got a grant funded to do that. So we've got a big randomized controlled trial, and we haven't published the results yet, so I can't tell you the answer. We had 588 people with low vision, and we got them to do a strength and balance training program, an individual home-based program. So we will publish those results very soon, because obviously people with low vision who cannot be rehabilitated, we need to do something, because their falls rate is quite high. And obviously their strength and balance is something we could address. So that was the rationale for that study. And also in Australia, where there are falls prevention programs, they often get excluded from them because people say, this is too hard, you can't see very well, we don't want to have you come to our group classes. And that's a problem too. So we want to make sure that they have some opportunity to prevent falls. So yeah, no answer on that just yet.
Yeah. So with that, I thank Dr. Lisa, and now I request Ms. Purnima, General Secretary of OATN, to introduce Dr. Srinivas. Let me share my screen once. Give me a second. Yes, Purnima, you can go ahead.
Thank you, Gopinath. So, good afternoon, one and all. It's an honor and privilege for me to be introducing our next speaker, Dr. Srinivas Marmamulla. Dr. Srinivas Marmamulla received his initial optometry training at L.V. Prasad Eye Institute, Hyderabad, and then he did his master's in community eye health from the London School of Hygiene and Tropical Medicine from the University of London. In 2011, he completed his PhD from the School of Optometry and Vision Science, UNSW, Sydney. Dr. Marmamulla has also done his postdoctoral research fellowship during 2012 and 13 with Dr. David Friedman at Wilmer Eye Institute, Johns Hopkins School of Medicine, Baltimore, United States of America. Dr. Marmamulla was the chief optometrist for many of LVPI's landmark studies like Andhra Pradesh Eye Disease Study 1 and 3 and Refractive Error Study in Children in the year 2000. He is the principal investigator for the Hyderabad Ocular Morbidity in Elderly Studies from 2017 to 20. He is also a teaching faculty at Brian Holden School of Optometry and Vision Science. He also has over 60 publications to his credit in peer-reviewed journals. His areas of interest are epidemiology of visual impairment, uncorrected refractive errors, presbyopia, eye health in elderly and other vulnerable populations, and training personnel for community eye care. With that, I invite Dr. Marmamulla to speak on eye health in elderly in the residential care.
Thank you for the kind introduction. Are my slides visible?
Yes, sir.
Okay. So let me take you through my experience of working with elderly people in residential care. These are the results mainly from our homes study. As we have seen, India is witnessing a demographic transition with increasing proportion of elderly people. On social front, the traditional joint family system is giving away to nuclear families. There is also changing living arrangements for the elderly, lack of social support, and these elderly are more vulnerable to vision loss, including other health issues and social well-being. In total, demographic shift coupled with social changes have significant impact on elderly populations. And we see that in India, as shown by Rizwana also, more and more people are living alone, only with spouse, or living in homes for the aged. If you look at the population pyramids over the years, in year 2000, about 20 years back, about 7% of the population were elderly. That became about 10% in 2020. And by 2050, it's expected that every fifth person would be elderly in India. And again, we have a vision loss expert group talking about the burden of vision loss in this population. If you see the prevalence of vision loss, it increases significantly with older age groups. If you look at 80 plus population, nearly 75% of them have vision loss. And when we talk about 90 plus population, more than 80% of them have vision loss. And we all know that vision loss has serious consequences on people. It leads to several issues like falls, as Lisa was talking about, and there are many other issues associated with vision loss. Given this background, we have undertaken ocular morbidity study in elderly populations in Hyderabad. The main objective was to understand the eye health status among elderly people in residential care in and around Hyderabad, to assess the impact of interventions for avoidable vision loss, and also to come up with strategies to address vision loss in elderly populations. So it was a longitudinal study. We have taken about 41 homes for the aged centers in and around Hyderabad. We had a very robust team of people, including study coordinators, optometrists, social investigators, and vision technicians. The study procedures include a comprehensive eye examination, fundus imaging, and administration of several questionnaires. It was a two-phase study. And phase one was the main baseline study where we tried to understand the burden of vision loss in this population, looked at the visual outcomes of the cataract surgery, falls and vision loss, and also looked at NCDs and disabilities. We provided intervention in form of cataract surgery and spectacles and ophthalmic lasers for all the people who need it. Then we went ahead and assessed the impact of intervention in phase two, where we looked at impact of intervention on visual functions, performance-based measures, falls and fear of falls, and also depression. So we went to each and every home, the 41 homes which I mentioned. We set up makeshift clinics in these homes and conducted all the assessments in as ambient testing conditions and standard conditions. As you can see, slit lamp examination, near visual acuity, and all the procedures were conducted. In total, 41 homes were included, 1,500 people were enumerated, and about 1,182 people were examined with a healthy response rate of about 80%. The mean age of the participants was 75 years with a standard deviation of 8.8 years. We had people ranging from 60 years to 108 years. We had about 6-7 centurions in our sample. Among those examined, 35% of them were men, 20% of them never had any formal education, 81% of them had cognition impairment, and about 18% of them were bedridden. When we looked at the visual impairment, about 3% of the people were blind, using the definition of worse than 3/60 to note light perception. 3.2% of them had a severe visual impairment, and about 24% of them had moderate visual impairment. In total, 30% of the elderly in residential care had vision loss. And when we looked at the regression analysis, elderly people more than 80 years, those who had never education, had no education, elderly in free homes, those with mobility issues and bedridden were at higher risk of vision loss. When we look at the causes of vision loss, 46% of those who had vision loss, cataract was a major cause, followed by uncorrected refractive errors and posterior capsular opacification. What is important was 88% of the vision loss is avoidable or needless. That means either we can prevent it, treat it, or correct it. We also looked at the near vision impairment. Half of the elderly in residential care had near vision loss. Most importantly, even among those who were wearing spectacles, 42% of them had near vision impairment, suggesting that their spectacles are inadequate. We looked at the visual outcomes after cataract surgery. About 16% of the participants had cataract surgery in at least one eye. What is ironical was a third of the operated eyes still had vision loss. About 43% of them had bilateral cataract surgery. In this one also, 20% of these people had visual impairment. Outcomes were better in NGO hospitals and in paid surgeries. When we looked at the causes of vision loss after cataract surgery, what was important was PCO was emerging as an important cause of vision loss after cataract surgery, followed by inadequate correction of their refractive errors. Again, a large proportion of this vision loss is needless or avoidable. And there was high prevalence of comorbidities. About 70% of these elderly had at least one comorbidity. 33% of them had at least one NCD. 26% of them had two NCDs, and about 11% of them had 3 or more non-communicable conditions. When we look at the disabilities, almost half of the elderly population had at least one disability. Cognition and mobility were the leading comorbidities or disabilities in this population. In summary, in the homes for the aged in Hyderabad, 30% of the population has distance vision loss. In addition to this, 51% of them have near vision impairment. In total, 81% of them have either distance or near vision loss. Most importantly, 88% of this vision loss was avoidable. 33% of the eyes operated had vision loss even after cataract surgery. PCO was a major cause, followed by uncorrected refractive errors. We provided intervention to all these people. About 330 people got spectacles and several people got cataract surgery done. And then we looked at the visual outcomes, impact of on the visual functions. In mobility scale, about 14.5% change was there in terms of mobility domain. In 20% change was there in activity limitation. And overall, if you see, about 16% change was there in total Indian visual function questionnaire scores. Coming to discussion, Holmes is one of the most comprehensive studies done in elderly in residential care in India. We found a large burden of avoidable vision loss. What was interesting was PCO is emerging as a leading cause of after cataract surgery. And as we know that we have aging population, PCO may emerge as a challenge given the increasing cataract surgical rate in the country, coupled with the increasing life expectancy. Most importantly, this project also shown that cataract cannot be considered as a one-time intervention because still a lot of people need glasses and laser for PCO. And definitely there's a need for elderly-centric eye care system. We got several publications from this project. A few more are in pipeline. What next? So we got a very good study now. We got very good results. But again, we should take this to service provision. So we took the process of reaching out to these people. There's a need for routine eye examination in the homes on similar lines of school health programs. We also felt that home-based care is necessary. Based on this, we started an initiative called as a Silver Sight Initiative. This is called as Eye Care on Call. This is typically a home-based primary eye care for the people, elderly people and those with disabilities, where we conduct eye examinations at the homes of the people, where we do refraction and provide glasses. We also provide teleophthalmology services wherever required, and we refer wherever cataract surgery or other intervention is needed. As of now, we are doing at no user fee. We published the protocol in iJava recently. Now, why should we talk about vision loss in elderly? Why it is important? Because good vision means better visual function and more years of life. We all know that visual impairment is also related to mortality. Good vision also means better quality of life, fewer falls. Good vision also means economic independence. If people have a good vision, they can depend on themselves. They need not be dependent on their other family members. And also, finally, we also know that healthy aging is equal to happy aging, and good vision is extremely important to achieve this goal. And to conclude, as Indian population ages, there will be increasing burden of vision loss. We need strategies to reach out to this elderly to provide care and to ensure that we achieve the goal of universal eye health. And it's our commitment that good vision in sunset years of life should be our commitment. To conclude, every elderly has a right to see this colorful world till the last day of their life. Ensuring that right is our primary responsibility. We are very much thankful to these elderly participants. Welcome Trust India Alliance has funded my project. Same is the case with HERF. Dr. David Fredman and Cynthia Osley helped me with the designing of the protocols. Most importantly, India Alliance was vital. It's a part of my early career fellowship. And a project like this magnitude is only possible when you have visionary leadership and also a wonderful team, always taking up the challenges, because working with elderly is always a challenge. This is the last slide. I'm happy to take my questions. Thank you all.
Thank you, Dr. Srinivas, for the excellent presentation. That was really good, like how community reach will help patients to improve their healthy and happy elderly living. Do we have any questions? Yeah, we have got one question. I read about your association between visual and hearing sensory impairment and suicidal ideation and attempt. What is your experience, doctor?
Okay, I don't know about the suicidal ideation attempt, but we did find that when we have people with single impairment, only visual impairment, and when you have people with visual impairment and also hearing impairment, the level of depression is high. For example, again, one of the paper under review, I should not be revealing the results, but what we found was the people who got dual sensory impairment, 60% of them are visually impaired, when compared to 30% with single impairment.
Okay, another question is, can you explain the home-based service protocol that got published, you mentioned?
So basically, when during the lockdown, we felt the need that we need to reach out to the people. So we developed this protocol, a simple protocol where we do the basic optometric eye examination. We do not dilate pupils there. We just go whenever people need eye care. We have popularized some numbers there. They call up that number. Within the radius of about 15 kilometers, our team will go and conduct examinations. If refraction is required, we have a pair of about 30 pairs of glasses where spectacles will be provided. If any ophthalmic consultation is required, we will do through teleophthalmology and medicines can be prescribed. As of now, we are able to see about 7 to 8 people in each day. We are doing in about 10 locations, but we want to take it to a much wider range. Now, the question is, when you can get a pizza on call, why not eye care, which is much more needed? So that's the goal, right?
I have got a question. Did you see any major difference in terms of urban and people who live in urban and rural? Was there like, yeah?
The burden is definitely higher, much higher in rural areas. We know the reasons, because uncorrected refractive errors and also the cataract prevalence is much higher in rural areas when compared to urban areas.
Okay. With this, I thank Dr. Srinivas, and our next speaker is going to be Dr. Vijaya Gotwal, and I'll be introducing her. Do we have any more questions? I don't see any questions in Zoom as well as YouTube. I will proceed with sharing my screen. Give me a second. So Dr. Vijaya Gotwal pursued her undergraduate in optometry from Elite School, Chennai, and subsequently she pursued her master's in applied sciences and PhD from Queensland University, Brisbane, Australia. She has a postdoctoral fellowship from Flinders Medical Center, and she is associated with Elvi Prasad Eye Institute over 30 years, where she has trained around more than 1,000 optometrists, and she is a very important person, considered as important person in developing and setting up the Mira and LB Deshpande Center for Sight Enhancement at the Institute to serve the patients with low vision. Her major research interests include outcome research in ophthalmology and low vision and it is focused on patient-reported outcome measurement and to see the effectiveness of treatments for low vision, specifically for pediatric low vision. And she had contributed in development and validation of patient-reported outcome measures using modern psychometric techniques. And her recent research is focused on cognition faults in the vision-impaired adults. She has published more than 100 peer-reviewed publications nationally and internationally, and have presented more than 130 presentations. And she is a reviewer for several peer-reviewed national and international journals. She has been awarded with various awards, and she is also a fellow of American Academy of Optometry and first Indian to be awarded a diplomate in low vision. And over to you, Dr. Vijaya Gotwal.
Thank you, Gopinath, for that wonderful introduction. Let me see if you can. I'll just try sharing my slides.
And as she shares her screen, she's the only woman from India that was listed in the Global Optometrist Top 200 research ranking, published in the Clinical and Experimental Optometry. So she's one of the world leaders in optometric research.
I
so
wanted to congratulate it at the end, but you did.
And I couldn't give.
I wish to congratulate Dr. Lisa also. She's also been listed.
Yes, yes. Way ahead. So
yes.
Thank you, Rizwana and Gopinath for that for the introduction and the lovely words. So my talk will focus on making life easier and safer for seniors with low vision. And so I think it's very important to put this in context, because we should know who is a geriatric patient. So it's not a disease because it's a physiological change. So a geriatric patient is a person who, as a result of aging and irrespective of his or her chronological age, has suffered decrements in physical abilities, mental capabilities, and psychosocial adjustments. So there is a lot going on as you age. And as we all know, life expectancy has changed world over, and Asia is no exception. India is no exception, and it is hovering around about 72, 71 at the moment in India, with the women obviously outliving the men by a little some years. So why should we care? Why is this age group important? It's important because, like I said, life expectancy has increased enormously. And of all the humans who ever lived to 60 or more, half are currently alive, and most of them are or will be your patients. So it's important from that perspective. So like Srinivas said, about 8.6% of the Indian population is 60 years and above. And as you can see from the numbers here, there's a projected 3% annual growth. And this is supposed to increase by 20% in 2050. So by 2050, there will be this huge population of elderly. And while the overall population is supposed to grow at 40%, the elderly population, especially the oldest old, it seems will increase by 500%. So there is going to be this huge population of the elderly. And you can categorize them. So when we say geriatric or elderly population, we can categorize them into young old, middle-aged old, and the oldest old. And it is usually the middle-aged and the oldest old that really need that care. So like I said, by 2050, India will have the largest number of older adults, and about 40% of them will have some or the other disability, like Srinivas also showed in his study from the old age homes. And about 20% will have mental health issues. But the mental health issues have lower prevalence with increasing number of years of education. So higher the literacy levels, lower is predicted the mental health issues, and if the younger age also. Now, if you look at the institutional care and the elderly that are there in this, so as you can see, over the last few years, this is rising. More and more number of elderly are in these old age homes or residential care. So in addition to vision, which we are all familiar with, it is very important to know that there are other issues, like even Srinivas pointed out. So while visual component is 88%, locomotor is about 40%, cardiovascular is about 17%, hearing is 88%, respiratory is 16%, genitourinary is 3.5%, neurological is close to 19%, and emotional well-being is again a big challenge. Depression, delirium, anxiety, and this age group is not very willing to talk about these issues. They are more reserved. They don't open up very easily. So there are challenges in being able to even assess their mental well-being. In terms of social issues, there is elder abuse, which is very common. They have financial insecurity. They are dependent on their caregivers, or for financial reasons, for emotional support. And financially, like I said, they have reduced financial resources. So they are not usually in the driver's seat to make decisions. So aging has a huge impact on the human visual system. So with the aging causes changes in the functionality of the central nervous system, which is responsible for activities such as vision-related cognitive ability activities, vision-dependent visual activities, then cognition, then visual performance. All these activities get affected. Now, if you this big study that was the ski study from Hagastoy, Portnay, Gunilla, which was done almost 2 decades ago. If you look at this very carefully, you see that the high contrast visual acuity, which is what I circled, you see that this rise in the contrast, the rise in the threshold for the high contrast visual acuity occurs a decade after most of the other visual functions. This is perhaps because the high contrast visual acuity is less susceptible to changes in the optical system, such as yellowing of the lens or any aberrations. So that's why if we only go by checking the high contrast visual acuity, we will miss on lots of the self-reported problems that these patients will keep complaining about. And then it is assumed that if their high contrast acuity or visual acuity is good, let's say about 612 or something in that range, then all the other visual functions also are good. But then research has shown that there is huge variability in the measures with age. You can have a 90-year-old having the visual functions of a 30-year-old. You can have a 60-year-old having the visual functions of a 90-year-old. So there is huge variability. And this variability, the gap widens with age. For the oldest age group, in that research, they showed that while the high contrast visual acuity was 618, the low contrast was only 638. And on the skill dark chart, the visual acuity was 690. In the presence of a glare source, it was 6/300. So the visual acuity loss was 0.5 log units, but the contrast sensitivity loss was 0.8 log units. So one cannot deduce the impact of the other visual functions in the oldest age group. They may have good acuity, but then if you look at the other visual functions, they'll be affected to a large extent. Then this paper by Ramsey in 1993 again shows very beautifully the discordance that is there between the self-reports and the objective test. So if you see that in the middle age, with the solid black bars, there is not much of a difference between what they reported and what the objective test found. But if you look at the old, then you see that there is a big divergence between the objective measures and the self-reported problems and the objective measures. And so this again conveys the point that one cannot just go by the recording of the high contrast acuity. Then there is this huge lower net study that was done by Goldstein et al. A few years ago, and about 28 participating centers in the US. They recruited close to about 750 participants aged 60 and above. And what this shows here is, in 2000, you see that this was the number of people who will require low vision services. But then in 2030, if you see, there's a sudden increase in that because of the aging population. And what are the causes that they found? Usual. So about close to maybe 1/3 or about 40% of the causes are all age-related macular degeneration, followed by then you have macular degeneration, inherited macular degeneration. So most of the retinal conditions, either it is age-related macular degeneration or the inherited retinal degenerations, comprise about half of the causes, followed by glaucoma, and then you have small proportions of other causes. So how does vision impairment affect the elderly? Now we all know that the loss of visual acuity is the first thing that we all recognize. But then how does it manifest? So they are complaining about typical doing activities in a day, like maybe writing, filling a form, using small tools, reading. So it is very important to have task-directed questions, because if you just ask them an open-ended question as to how is so blurred vision is a very non-specific thing. But then if you ask them leading questions, that do you have problem in performing any of your daily activities like reading, watching television, which are the common things that this group will do. And then loss of contrast sensitivity, again, cannot be overemphasized. They'll complain of problems with recognizing people that come to their homes. They cannot strike a conversation because they cannot see those gestures, whether they are smiling, frowning, seeing curves, drop-offs when they are walking. And like Lisa and Srinivas mentioned, this is a huge risk factor for falls. And then we all know that there is decline in the low contrast acuity with age because of the reduction in retinal illumination because of the meiosis. So with pupillary meiosis with age, there is decreased transmission through the pupil and the ocular media. And also there are these cortical changes that happen. So there is decreased binocular summation. And because of the increasing amounts of ocular pathology with age, one is the minimum that happens is the yellowing of the lens with age. And then you have these diabetic retinopathies and other things that are going on. And then we all know about the loss of peripheral visual field. So there is reduced postural stability. So there is a lot of postural sway in their walk. So if you look at their gait pattern, there is a lot of postural sway there, and that can be one of the risk factors for falls. They have difficulty locating obstacles, driving, seeing street signs, avoiding collisions while walking. And then you have these patients with age-related macular degeneration, let's say the wet or the dry, where they have central scotomas, or treated diabetic, proliferated diabetic retinopathy with lasers. So you have these objects and text that are simply disappearing. So it's very frustrating for them to read. And they'll complain of issues with dark adaptation and light adaptation. So they require time to adjust. So the moment they step out of their home, they need that little time to adjust to that light outside and dark adaptation. Like if they ever happen to go to the cinema theaters or something, they're not able to find a seat when they're entering a dimly lit restaurant or movie theaters, which are typically very darkly lit. And then comes the glare disability. Now, so what is glare disability? It is loss of vision when a bright light source illuminates the eye when viewing a much dimmer target. So like, for example, this traffic lights with the sun low in the sky, and then these pavement markings against oncoming headlights at night. So this glare, so as you can see on this figure down, so you see this disability glare and glare recovery. So you see this, it increases with age, the disability glare. And you see again the glare recovery also. So see this, how rapidly that changes with age. So, and you can assess glare disability. You can have the Berkeley glare test. You can have the brightness acuity testers. You don't even need to do this. If you just ask them, or if you just take them outside, they'll tell you that this is very hurting on a sunny day. And then stereopsis. So we all know that stereopsis, again, see if you look at this from that same paper, you see how the stereopsis reduces drastically with age. So no wonder they have these, they misjudge depth. So in terms of pouring liquids, parking a car, threading needle, and then falls. And color vision again. So they have difficulty with differentiating between colors, and mostly it will be blue-yellow deficits. And this is because of the presence of cataract, age-related macular degeneration, glaucoma, diabetic retinopathy. So like I said, they are not the decision makers more often than not. And they are so dependent on their immediate caregivers or whoever they're living with. They have poorer physical and mental health. They have social isolation, so less social support, loss of balance, falls, and their visual processing is slow. Visual perception skills are affected, and there is reduced spatial orientation and awareness. And in conditions when there is an ocular pathology, let's say like glaucoma, or let's say there is age-related macular degeneration, so there is more visual stress, and they have all musculoskeletal complaints. So as a result of visual impairment, the balance, like I said, there is postural sway, there is decreased balance control, and both Lisa and Srinivas alluded to this. There's greater fear of falling. So which, as a result of which, they are very homebound, and there is activity restriction. And so what is the role of the low vision service provider? I think the first and the foremost, given the knowledge now we have, I think it is important to recognize the risks for falls. So screen for fall history. The minimum you can ask is, have you ever had a fall in the last year or so? Because that is the most recent memory. And you can observe the patient's vision and motor control. And if there are visual functions that are impacted, then that is something that needs to be considered. And like Lisa said, it is important to maximize binocularity. So appropriate glass prescription. So many a times, probably giving two separate pair of glasses, though it is cumbersome. Many a times, even research has shown that when there is bifocals, so what happens is they cannot see the lower portion. They are trying to see the lower portion through the bifocals. So they have to be told that they have to drop their head so that they are able to see through the distance portion. This small tip when we are giving them new glasses or giving them bifocals is very important. And then it is important also to refer for false assessment, where quick screen is a very efficient and very easy tool that can be applied. So as a vision rehabilitation provider, like I said, it is important that we help patients maximize vision through training and devices, educate patients on safety while moving, and refer or even teach them compensatory strategies to optimize function. So the goal of low vision rehabilitation is, the bigger goal is to reduce the impact of visual impairment and minimize the visual disability. Now, traditionally, the prescription of assistive devices like magnifiers, you can have CCTVs, but in the last few decades, with the technological advancements, even a simple mobile, which is a smartphone, and many times you'll find that the elderly are sometimes tech phobic, and especially the oldest old. So they are tech phobic. They will have those, they'll not have the smartphones. They'll have the Android phones. The keypad will be there. They'll be struggling there because it is small font. So I think it's just a matter of getting them used to it. And all these smartphones come with features, accessibility features. So many a times, even they will have the smartphone, they will not know what the accessibility features are. It's just maybe a 2-minute job where you can show them how it can be done. So they have text-to-speech output is there. And mobile technology itself can be used to Zoom. They can read with that. They can do lots of other things with it. And it's essential also to stress upon environmental modifications, like you see in this room here. So it is important, at least in places, at least within home and other areas where it is possible to highlight the drop-offs and the edges so that they don't bump. Like Lisa mentioned, rugs are there, so they get entangled into that fall. So it reduces the visual demand. And it is important to refer for management of comorbidities. Like you'll have these patients with diabetic retinopathy sitting there, and they'll have these diabetic neuropathy, the kind of shoes they should be wearing, all the other comorbidities need to be managed and need to be referred. In terms of lighting, so critical because it is the direct task lighting that is important. We all require about 600 to 800 lux that is required for tasks that are reading, crafting. And it is important to advise them to use special bulbs, lights, because it increases contrast, reduces glare. And something that the elderly do not appreciate is turning the lights on during daytime when they are indoors. And they don't get that concept very often. So it is important to educate them on that. And then when they go out, it is important to wear visors or peak caps, sunglasses, mostly photo gray or photochromatic or any of those tints, so that they are not having problems with light and dark adaptation. And so for a healthy 55-year-old, requires a 540 lux to read small print. And there is this HeLa instrument which is used to assess the lighting levels. And the research done almost 2 decades ago, again in the developed world, showed that home lighting was well below recommended levels. So we can imagine what's going on in our homes where we have our elderly. And older adults, like I said, they do not appreciate the role of lighting because they rate home lighting as adequate. Anytime you ask them, self-report will be, yeah, I have enough light at home. And you go and really do. So these occupational therapists, it falls within their realm of occupational therapy. When they go and do these assessments, they find that is more often than not inadequate. And like I said, the HeLa instrument is there for assessing home environment. And it is so crucial because they spend about 12 to 14 hours at home. So home lighting is very, very critical. And like I alluded to earlier, in the lower net study, they assessed the emotional well-being. 42% were frustrated, a quarter were depressed, and a quarter were anxious. So, and they reported general health was good. Now, good. And what did they find? They had falls, they had high BP, they had pain, but they rated their general health as good. So there is so much discordance between their self-reports and what was found. So for low vision rehabilitation to be successful, it is so important that the comorbidities are taken care of. Otherwise, it's going to fall apart. And the devices and the interventions need to be task specific. It cannot be one size fits all. There are lots of gaps in the low vision service delivery because what happens is there is underreporting by the population, by the elderly population themselves, because they consider it to be a normal concomitant of old age itself. So they're reluctant to report problems. One, there is a problem on our side because we are not probably having those task specific questions and leading questions we are not posing to them. Two, they are reluctant to report their problems because they consider it as a normal aging process. So like I said, it is so important to incorporate task specific questions. For example, you can have questions like, does bright sunshine affect your ability to read street signs? Do you have difficulty reading? Do you find it that you can read outside home better than inside your house? So it gives you some insight into their person's visual performance, so you can help identify their declines. And like I said, it is not the patient motivation and support is so important because and the caregivers and the community can play a very big role in this. And it is important to increase awareness about the benefits of low vision rehabilitation. At the community level, so much can be done because it's important to raise awareness that it is not aging. It should not be, the vision loss should not be taken to be a part of aging process. There are interventions that are possible, like Srinivas has shown, glasses, cataract, and other things, and other interventions, even PCOS. So yeah, capsulotomy needs to be done. Otherwise, it's considered as a one-time process. And it's important to identify and refer and provide basic home-based rehabilitation. Like home evaluation can be done. You can have rehabilitation professionals, or you can have occupational therapists. You can have low vision therapists doing these things. And so this will make life easy both for family members, and it will make life easier and safer for older persons with low vision. Most importantly, it improves safety. So it is important to have the home organized and not disturb the surroundings of an elderly person, because because memory is an issue with them. So if they've kept something there and if you move it out of there, then they are only searching for that. And the rugs, the kind of environment, lighting, the kind of organization that is at home. So knives, so you don't want to have them on the floor because they are not looking very carefully. So it's like having kids at home. So, and it's important to improve color and contrast. And then you can have at least sighted guide technique for mobility within home or little outside home, because the radius of movement is not very much, at least in the oldest old. So there is temptation usually to prescribe an array of magnifiers. And if it is unsuitable, they lie unused. So it is very important that it is the assessment is done within the patient's home also, because research has shown that if they're able to read and perform whatever activities they want to perform in the clinic, it's not necessary that, because in the clinic we have all control conditions, but when they go home, they are not able to perform those tasks. So it is sometimes advisable to provide little more magnification than what you see in the clinic, so that you're sure that they'll be able to perform reading tasks at least with that device at home. So the needs of older persons with low vision will vary, because it's not, again, like one size fits all. It will vary with the economic status, the requirements, the literacy levels, the kind of family responsibilities, whether they don't have any more family responsibilities or they still have to support a family, and their attitude in general towards aging and disability. How do they consider healthy aging, or they've given up? And then general health and the motivation towards life in general. So I thought I'd leave you something with basic advice for geriatric patients. So everybody can carry a torch while going out in that age group, and that age group knows what a torch is. So, and when they go out, it is important that they shade their eyes. They can sit close to TV between 4 to 5 feet, increase screen brightness. Reading, they can use maybe a low power magnifier, use a gooseneck lamp or a reading lamp, so task specific. And while shopping, they can carry a pocket magnifier. And for telephone, they can again use a torch or a suitable magnifier, something like that. For eating, they can have a glare-free light source about the dining table, so they know what is there. Otherwise they have no clue what they're eating sometimes. And in the kitchen, maybe they can have glare-free light sources directly above the stove and above the sink. And it's very important they keep their spectacles up to date and in good condition. And it's important to tell them that please don't save on your electricity bill. Thank you.
Thank you. Thank you, Dr. Vijay Kumari, ma'am. And this was again excellent and comprehensive presentation. And we have some questions from Dr. Aishwarya. And we find this trend in this age group to be increasingly independent in the recent years. Has this affected the seeking of or acceptance to assistive devices?
I think so. That again, it's very varied, because at least from what I have seen, you will have a 95. Yeah, sometimes you get a 95-year-old coming, and they'll be sometimes mostly on a wheelchair or something, saying, I want to be able to read, and coming with a grandchild, And then you'll have these 60, 65-year-olds saying, I'm done, I don't have anything else. So I think it varies with, like I said, it is dependent on lots of factors. And I think it's the personality of the person. There are people and low vision devices can serve only a small purpose, right? We all know this. It's only for any reading or any literary tasks. So if the more the person is a literate and is a voracious reader, that is when they would come asking for things. So it is very open. And I would say, I think from what I see, maybe 1% would be in that 80 plus age group that would come seeking services, and they'll come on their own. They don't need a referral or something. So, and so that's I don't know if I've answered the question though, but I sitting in a tertiary eye care institute, I think it's difficult to make that because more often than they're referred, and then once they're referred, and if they're in that elite category, they're like, okay, I've seen these devices. I have some grandchild who will send it to me from the US and things like that. But then you'll have those and then they'll come looking for spot reading. Prolonged reading is not a task that they come looking for.
Yeah, thank you, ma'am. Considering the time, I think we should move ahead with the panel discussion. And we'll begin the panel discussion with the experts from optometry, low vision care, community eye care, geriatric, and yoga therapy. And now I request Dr. Krishna Kumar, former principal ESO and freelance optometrist, to introduce our one of our panel member, Dr. Harishankar. Over to you, Dr. Krishna Kumar.
Thank you, Gopi, and thank you for all these wonderful speakers. And I have a pleasure of introducing one of my good friends, Dr. B. Harishankar, who is a geriatric physician and faculty of ESO for more than 5 years teaching geriatric optometry. He is the founder of BHS Geriatrics and Diabetic Center in Chennai, in a place called Kilkatlai. And the wonderful thing about him is he has taken elderly care as his topmost priority in his life, not just making them come to his OPD or taking care of them in inpatient services. The uniqueness of it is that he goes to their home every day, not one day or one day in a week, every day, between 2 to 6 times more than that, 2 to 9 also. And he has catered to almost 25,000 plus home visits and people. And also, in addition to that, he also very keen to train other professionals into it. And one such initiative is very keen that optometrists should be part of this geriatric care. And very happy to see that in addition to that, he's also training nurses in this geriatric care in this part of the country. It's a pleasure to have him in the panel. And Gopi, it's yours.
Yeah. And I request Ms. Ramya to introduce our one of our another panel members, Sanyasi Krishna Yogam, and request Dr. Ms. Ramya to take over the panel discussion. Thank you.
Yeah, thank you, Gopi. It's my pleasure to introduce my Guruji, Sanyasi Krishna Yogam. He is one of the disciples of Paramahamsa Swami Niranjanananda Saraswati of Bihar School of Yoga. He is the director of Satyananda Yoga Center, which is an unit of Satyam Yoga Trust, Chennai. His academic qualification include PG in Arts, Diploma in Software, Hardware and Networking. He had worked in software, hardware as well as in networking areas. He was born in a sannyasi family and grandparent being a sannyasi, and learned the initial lessons from both his grandfathers, one being a sannyasi and other led a yogic life. He joined his guru in the year 1984 and took lessons in the yoga teaching. He also has established yoga centers in Bihar, Odisha, Andhra, Kerala and Tamil Nadu. He also has established an ashram near Pondicherry, and thereby with an experience of guiding people in spiritual matters since 4 decades. He has given yoga training for people of all the age groups for prevention and treatment of diseases like high BP, low BP, diabetes, arthritis, stress, insomnia, etc.
You came here, is it? I'm meeting.
Okay, his team is currently providing yoga services to public in various centers in Chennai under his guidance. His team also gives training for visually challenged people in Chennai under his guidance. He is also involved in social services associated with old age homes, orphanages, managing and organizing cataract surgery camp, as well as taking care of post-operative care for the patients in eye hospitals. He is also instrumental in educating first-generation poor children belonging to village areas. Once a year, all over the Tamil Nadu, he is conducting more than 25 yoga camps to spread yoga from door to door and shore to shore as part of his Guru's mission. Pranams to Guruji. So, as we have 3 speakers which have already delivered their excellent talks, and the 2 panel members who have joined recently, Dr. Harishankar and Guruji. So, we will move on to the panel discussion. We have the following domains as the expert talks, which is optometry, low vision, geriatric care, yoga, as well as community eye care. So, shall I start, Gopi?
Yeah, please go ahead.
Yeah. So my first discussion would be with Dr. Lisa. So Dr. Lisa, I would like to know what is the burden of visual impairment in elderly, as well as the challenges faced by them, more specific to India.
So the question's about India, or?
Yeah, you it was already discussed worldwide, so it would be better about your experience with respect to India, because in your talk I heard that you have worked with many people in Indian setup.
Yeah, so I think I mean the types of eye conditions are the same around the globe, really, and you know India's undergoing a rapid epidemiologic transition and rapid aging of the population. I think that my co-presenters articulated that very nicely. I mean, one point I wanted to bring up is that we're also looking very closely at people in residential aged care facilities, so nursing homes in Australia. And we find that people with poor vision, like Srinivas mentioned, also have poor hearing often. And this sensory loss is quite closely linked to cognitive decline. So we're looking very carefully now at how we can help people who, you know, we need to rehabilitate their vision, but we also need to ask them to comply with using the aids we give them. So it was nice to hear from Vijaya as well about the importance of good lighting and good environmental conditions for optimizing sensory rehabilitation. So I think I'm not sure I've answered your question, actually. I think I don't have the data to hand about the major crises in India as far as eye diseases. I think some of my co-panelists would speak better to that than I would. But I think it's really important to start thinking holistically and thinking about how we get people to engage in rehabilitation of their vision when they get older, when they have a lot of other health conditions causing them troubles. So we need to think holistically about patient care.
Thank you, Dr. Lisa. And over to Vijaya ma'am and Srinivas sir. What is your take on about the challenges of elderly people with visual impairment, especially in India?
The research that we have done in the populations have shown that visual impairment burden about 30%, 30 to 33%, both in residential care, both in population-based studies also. In a large study that we have done in the population, with a large sample in 4 large districts, we felt that 33% of the people are having vision loss, using a definition of 6/18. Out of that, 90% is because of cataract and refractive errors. This is what we found in Telangana region. The problems faced by these people, again, Vijaya has clearly presented in their talk, what are the implications of all these, and we know that falls. And also we see that in elderly, visual impairment is not a single package, sort of, it comes with other issues related to hearing and several other things. And now increasingly it is recognized that mental issues are important in elderly populations. So what I feel is that, again, coming from eye field and optometry field, I feel that if you only look at eye health as a separate vertical, we are bound to fail. We really need a more holistic approach. My experience of working with elderly people has clearly shown that if you say vision impairment and then say that things are going to change, that is very unlikely. We need to really look at vision and all the surrounding aspects of it.
Yes, sir, absolutely right. And I would also like to know, Dr. Lisa, what are the eye care seeking behaviors for preventing ocular diseases with respect to the elderly patients?
I mean, building on Srinivas's and Vijaya's recommendations, it's still about getting access to cataract surgery, getting the right glasses, and getting people to maintain them and wear them. There's still the other conditions, so detecting glaucoma, detecting and managing other conditions such as diabetic retinopathy and macular degeneration. So they're all of the things that we've really got to be mindful about. But I think as eye care professionals, we know how to do those things. But we need to, I think the theme that's coming through today is to work collaboratively with other health professionals so that we can get the best outcomes for our patients. I mean, I do very little clinical care, but when I get out and meet with older people, you realize there's so much going on in their lives. And we've talked about economic hardship, feeling disenfranchised, feeling unhappy. COVID has really hit older people enormously, I'm sure, as it has the whole of our communities. So it's complex, and I think we have to innovate and think of the best ways to engage with older people so that they can have positive health outcomes and live productive and engaged lives in their later years.
Thank you, Dr. Lisa. Over to Vijaya, ma'am. Can you just share your experience on low vision devices provided to the elderly people? You have extensively explained it in your talk. I would like to know what are the major domains which the elderly people would be wanting, whether it is for mobility or for distance vision or for near vision or anything else.
So see, low vision rehabilitation is a philosophy. So regardless of the age group, kids will come and tell you, I can't see the board. Anybody who is, let's say, 25 plus, face recognition is something that bothers everybody. They say, I can't see the face of the person. And so there is very little you can do about it, because face recognition is it's a contrast task. And to improve contrast is not easy. But you can do this when you have vision stimulation for infants. You can tell the mother she can make those changes and all those things. But when it comes to face recognition in the adults and among the elderly, that is something that is very, very challenging. There's not much we can do about it. But so if you neglect that, and if you come to other tasks, low vision devices serve the purpose, a very small purpose. Let's say only for reading, for literary tasks. Now, reading is a very big term. You got to break it into smaller goals and say, what do you read for? Do you read for pleasure? Do you read spot reading? Do you just want to check bills? When you go shopping, do you want to see all the MRPs? So there are many things that people want to be able to do. So it is very, like I said, it's very important to ask, pose those leading questions to them. Say, what in reading are you looking for? Because reading speed, we know, right? And because of all the pathological changes that happen, reading speed slows down. And if you're not a voracious reader, you're not much very interested in reading. And just 2 days back, I had this, I had this gentleman. He must have been around 65. And like I showed him, he's able to read N8, he can read the newspaper. He was very content with reading only the headlines. He didn't want to read anything beyond that. He said, once I read the headline, I know what is the matter there. So he wasn't very interested in reading the a small font. So it's not one size doesn't fit all. So it all depends upon the person, right? And the what are their needs there. So I think a bunch of magnifiers is very useful. It can be the LED stand magnifiers, it can be pocket magnifiers, it can be stand magnifiers. And very more often than not these days, I just ask patients to take out their, if they have a smartphone, I tell them just take out your smartphone. I'll show you on your smartphone what you can do. And more often than not, the very small thing, I'll just go to accessibility features. I'll show them that it's like magic, I'll be the magician in the room. So sometimes it's embarrassing because they wouldn't know that is existing. And then they'll have that daughter, son-in-law and say, look, I was trying to tell you, but see, when she's telling you, you're listening to her. So there'll be these arguments that go on in the clinic also. So so I think with the technological advancements that are happened, and the tech-savvy ones know it. So they are not the ones that are coming seeking these services. So they are not coming to us. It's only those ones that cannot find these things. They are not aware of it. They're little tech phobic. And there's like, I can't handle the mobile. No, I do not want to use the mobile. I'll not be able to do it. But once I think it's just talking into them and talking to them about it and telling them, see, this is what it is. You don't need a magnifier. If you just zoom this, you'll be able to do this task. So I think at least literate us. And as far as mobility is concerned, they are not very, at least the ones who have advanced field loss less than, let's say, 10 degrees, they are not the ones that want to be mobile anyway. So they have support systems in place. Either they have a sighted guide or they have mobility cane using, again, is a very, very small fraction. And you tell them it is for safety, they say, no, I don't go out itself. And then so what they do is they go into this small social isolation. So I tell them the impact of social isolation. But then they say they have grandchildren at home, they're happy with that. So subclinical depression is there. And if you apply the PHQ-9, you'll find very often than not, you'll not find any depression on that. You can use the GDS also, you'll not find any depression because it is always underreported. So there is social desirability bias when you use these questionnaires. So that is why there is a lot of underreporting that is happening there. So I think it's just a striking a conversation. And once they establish that rapport with you, then they share many things with you. So many a times, even in the CCTV mouse model works but then it limits their place where they can read. They'll need the TV there. If there's only one TV at home, there are competing interests there. So then you can have portable video magnifiers, then they're a little expensive. So that's why I said, so as a practitioner, I would give them the range of options, leave it to them to decide so that they make an informed decision and choice. And that way there is compliance is higher and there is it's better used that way. So I would put it that way. Plus, I would always advise for home visits, say that if somebody can do a home visit, ideally it falls within the realm of an occupational therapist. Go and see what kind of lighting you have at home, because many a times the same magnifier, they'll be able to read here, they'll not be able to read at home, because you ask them, they'll say, oh, there's adequate lighting. You go and see, half the time the lights will not be on, or there'll be inadequate lighting in areas where they are sitting and reading. So I think that is how it is.
Thank you, ma'am. And I would also like to ask you how the low vision services can be availed by the needy elderly people, because people coming to the hospitals will definitely get the referral and they would avail the services. So what about the people in the community?
So it is the same thing, regardless of the age group, community-based rehabilitation can be done, right? So there can be home visits. That's what I said. So it's going to vary by rural versus urban population. The rural population probably is not very keen on doing an literate tasks or something. If they're able to perform their daily activities, that should be fine with them. And only the severe vision impairment people will have problems with performing daily activities. Otherwise, it's mostly moderate vision impairment. Moderate vision impairment usually are not having huge problems in mobility or being able to perform their daily activities. And the ones who have severe vision impairment can be trained within their home. So we have community-based rehabilitation workers that we have with all our secondary centers. They go to patients' homes, have do home visits, and then they give mobility training if required within that environment, because they're not going to come and walk on this on these terrains. So the terrain is very different there, and to be able to usually elderly in that age group, they are not performing too many tasks, even normally sighted also, at least 75 plus. And the 60 to 70 is anyway helping in household chores at least, but the 75 plus is anyway sitting there. And so if they're able to so like Lisa and Srinivas said, because there are other issues that are going on. They have hearing impairments, so the dual sensory loss is there. There are locomotor issues, physical disabilities there. So because of that, within their environments, if rehabilitation services can be provided, that is the best thing.
Yes, ma'am. Thank you, ma'am. So now I would like to ask a few questions to Dr. Srinivas, sir. So, what is your experience on geriatric eye care in the community? You have shared extensively based on a home study. Can you just share your personal experience related to few patients as well, sir?
So we do have something called as the Silver Sight Initiative that I was talking to you about. This is started about several months back, about 9-10 months back. We have completed about 1,500 consultations as on date. Basically, what we do in this, these are typically linked to the vision centers and secondary centers in rural areas where people can book their appointment. Once they book an appointment, our team, optometry team, can go and conduct examinations. Typically, they have a small kit they carry, they do simple slit lamp examination. In some places, they do fundus examination through non-Geriatric camera. We don't direct pupils there. They check visual acuity. We use something called peak. You might have a peak, a simple acuity that is commonly used. Peak acuity is used. Near vision is assessed. Refraction is done. If they need glasses, we have about 30 pairs of glasses. That includes single vision glasses, ready-made glasses, and also best sphere glasses. Spherical glasses can be clip-ons are there. From 30 pairs of glasses which they can select, they have to buy for the glasses. If they need any medical referral, for example, any consultation is required, we book a teleophthalmology consultation. We do a video call. The optometrist will dial to the command center. The doctor can see and provide medication. And if a referral is required, for example, advanced cataract, then they are referred to our secondary centers. So this is what happens. Typically, they do about 7 to 8 consultations in a given day. Currently, this is restricted to 15-kilometer radius from each of these vision centers. Eventually, we want to do this through all the 200 vision centers that we have.
Yes, sir. Thank you, sir. That was a great initiative. So now I will ask the other panel members related to geriatric eye care and yoga therapy. So over to Harishankar, sir. So what are the geriatric genes and how that can be prevented?
Yeah, good evening all. And coming to the topic, I'm first of all happy that you're all engaged with low vision and falls, because we always think that from a medical fraternity, we are the ones who are fighting for fall prevention. And as we all know, vision is a very important problem. If you consider the geriatric genes, among the 5 important geriatric genes, falls is a very important problem in elderly. So why we are worried so much about falls is because of the consequence of the fall. Because as Dr. Padma Shri Natarajan sir says, the first fall is the beginning of old age and the second fall is the end of old age. Fall is fatal in old age. What was a simple fall in our early childhood becomes fatal in elderly. And what are the consequences of a fall? Is it reduces the lack of confidence of elderly, lot of compression fractures in the vertebra, and the alone living, sometimes they fall and they even die because of subdural hemorrhage. So this is very important. And as I've been observing right from the first speaker and till the last speaker, ma'am, So you are all telling about the various causes and how to correct it. And I'd like to just throw some light on the other common causes of fall, because as Dr. Krishna Kumar sir, who has introduced me to ESO and also introduced me in this virtual webinar also. So he also always used to tell me to empower their upcoming optometrists to know about the other medical problems that the elderly can have. The elderly can have osteoarthritis, which itself, because the hip joint and the knee joint are very important for both stability and mobility. The upper limb is very important only for mobility, whereas the lower limb, the pelvis and the hip and the knee and the ankle is important both for stability and mobility. Osteoarthritis, as a consequence of obesity in elderly, can also cause a fall. Nervous problem related with central nervous system like Parkinsonism, stroke can also have a fall, and lack of proprioception, because barefoot walking was one of the common culture across all over the world, but barefoot walking has slowly reduced by the invention of chappals. Though barefoot walking is not advised in diabetics, but still barefoot walking improves a lot of stability in elderly, because Leonardo Vinci says the masterpiece of the creator is the pair of feet that we have. A unique number of 28 bones arranged fantastically at the feet with lot of proprioception gives lot of stability, and that stability is simply marked by chappals and the footwear what we use. So in this talk, I'm not against using footwear or chappals, but let us begin a change from our children. Let us train them by walking barefoot. Barefoot improves stability. And then we have the 8th cranial nerve, the vestibulocochlear nerve problem. Then we have cerebellar small vessel ischemic changes. As we know, diabetes and hypertension is very rampant. Atheroscleromatous changes can cause small vessel ischemic changes in elderly. And of course, drugs. As you know, elderly have a variety of a basket of drugs. They have a basket of drugs. Sometimes, as already well mentioned, that subclinical depression is very, very rampant in elderly. So the physicians prescribe some amount of sedatives for elderly, which increases the tendency to fall. And syncope is very, very common in elderly, especially postural hypertension. Whenever they get up from the bed, especially to pass urine and stools early in the morning, they have a fall just even within their living room. And just I have noted a few points just to say, an alone living elderly, social isolation is a very big problem. As I would like to end my point here to tell me from a few verses from Tirukural. Utravan Tirpan Marundulai Selvan Endru Appal Narkutre Marundu. Utravan means the patient, Tirpan means the physician, Marundu is the medicine. Tulai Selvan means a person to be there along with the patient to take care of him, issue the medicines, give the medicines is what lacking. We have patients, we have medicine, we have doctors, but there are the entire big house in wherever the elderly are living is so scarce, and it is the elderly are almost living alone. So as all religious books says, taking care of the parents is the firstmost responsibility of every child, and it is answerable on the judgment day also. With this point, I like to convey all whatever I want to convey to you all. I have conveyed. If there are any shortcomings, please apologize. Thank you.
Thank you for the wonderful thoughts, sir. Over to Guruji. Guruji, can you just tell us what are the possible yoga interventions that can be given for elderly people to lead an independent and healthy lifestyle? Guruji, please unmute your mic. You are speaking, but we cannot hear you. Yeah.
Is it okay now?
Yes, sir.
So let me pray for good health, peace, plenty and prosperity for all the panelists and other listeners. The speakers here gave a very good idea about what is happening all around the world on this subject. I am happy that doctors and scientists like you are on the job. Being a senior citizen, I am very happy that I will also be benefited from your. Coming to the subject, as Dr. Maramulla Garu and Dr. Harishankar, etc. mentioned, it is not only the vision, but there are other factors connected to this issue of falling in elderly persons. We mainly are concerned about the vision because that is the main subject here. But there are other points like ear fluid. I'm not telling anything new, but the ear fluid condition, the center of gravity, the balancing functioning of the brain, etc. are playing major role according to our understanding in yoga. So we teach yogic postures and other practices, taking all these points into consideration, not only the vision point. All these put together only can a person balance. Vision, ear fluid has to help him, and then orientation. And for that, the cerebellum should help him. And hence we should keep all these areas healthy. So the practices will be aiming at keeping all these faculties healthy. Another point is, as a person grow older, in my opinion, more than the heart or lungs or other critical organs, the lower limbs should be given due consideration. That is not given in elderly people. They themselves don't give, and they don't seek advice probably, or even the medical fraternity take a little more care in educating the elderly people to take care of their lower limbs. That is very important. Your heart may be healthy, your eyes are good, but if your lower limbs are not healthy, you cannot walk, you will fall. So we concentrate on that part also. So in the my observation, having worked with the visually challenged people in eye hospitals as well as in certain centers where only visually challenged people are living. There are certain centers in Chennai like that. My experience working with them is that their other faculties are much more powerful, as you people also know about it. So we should take care of, make use of such faculties and train them to manage from falling. And this has to start from an early age, not only visually challenged people, but also for everyone, because God willing, everybody is going to live the old age life. So geriatry is going to be faced by all of us. I am already facing it. But thanks to yoga that I never had such problem. And I learned certain techniques from the martial arts where I was well trained, certain falling techniques. And these techniques also can be applied in everybody, is case elderly or even younger people. So if you get a clue of falling, you fall in a particular way. And when I was trained in roller skating in my younger days, the first lesson I was given was how to fall. Means mostly the falling in roller skating is backward falling, and your back of the head will be hitting the floor. So we are trained to fall backward, and the falling method is like this. For just I don't know, that mistake allotted to me, but from an younger age, if we can train people, this will be useful. That you have to immediately sit. If you think of falling, sit down. and you will be hitting your buttocks on the floor, and you will be rolling backward. And if you can train yourself to lock your chin on your chest, your head will also be safe. And most of such a fall during roller skating can be fatal even. So coming to yoga, we give training to the cerebellum part of the brain, because that is, as you know, I'm a doctor, I know, and medical scientist. So that plays a major role. Any other part of the brain. So we give training to such a part of the brain so that it does maintains its good health as well as plays its role. And then the Sushumna Nadi, okay, I have to come to the normal term, spinal cord. The spinal cord is also very important. As you know, it helps us in communication. So the communication is very important. As you might have seen in my resume that CV that I worked in communication. So I used to link both these Sushumna Nadi and network cables. So it plays a vital role in sending messages about fall. So we have to keep the spinal cord also healthy, so that the communication is very proper and fast. So we have certain practices. For example, for the body part, we have certain asanas. I may just spell out few asanas like Tadasana, Tiryak Tadasana, Kati Chakrasana, Yegapada Padmasana, Natavarasan, Garudasana, Tadasana, Natarajasan, Yegapatmasan, like that. The list goes like that. It's not that one has to practice all these asanas. It may not be possible. So what we don't treat the problem, but we treat the patient. That is the difference here. What is suitable and possible by the individual, we teach them such asanas. All the asanas are not required, and thereby strengthening the muscles and the motor system, and good coordination between the muscles, joints, and the brain. So this balance is very important. Body balance means the total system balance. And for the Nadi system, we have mantras to be chanted for the whole sympathetic and parasympathetic nervous system. We have practices in Nadi Shodhan Pranayam, Brahmari Pranayam, and mantras. So I don't know the mantra part, how far people will release here, but that's a fact. I can speak from my experience. So, and as universally known, palming is very good for this practices. This not only for balance, but it can help a lot in maintaining your eye health. Palming, there are so many types of palming are there. For example, want to say generally rubbing 5-6 times and making some heat and covering the whole face, not only to the eye. And in the yogic system, we don't touch the eye. It is the Ida Nadi and Pingala Nadi energy coming together, and the whole body's energy is passed on to your face, and the eyes being very sensitive, it will absorb the maximum energy. It is the two sides of the energy, the positive and the negative, or Ida and Pingala, or Purusha and Prakriti, or Shiva and Shakti, etc. Whatever way you can take it, you may take it, you may take it. So that energy helps a lot for the eyes. So palming and the Brahmari Pranayam, when you hum like a bee, that goes and activates the whole nervous system and also the brain. Not only the cerebellum, but the whole brain, and the especially the medulla oblongata and the hypothalamus. These are, though they are sitting in the back of your brain, but they plays a major role in this. But not much, I think, is spoken about it. So this type of practices are going to help, and I'm not going into detail because this is not the quorum fact. But one or two points from the scientists of this subject spoken here, I would like to consider, because I don't consider yoga as an isolated system for body, but the emotion is an important point in human life. Of course, in animal life also it is important, because I live with the animals, so I know the emotional quotient of the animals. This is very important in any creature. So we spoke about isolation. Isolation is another point we have to take care. And in yoga, we teach people to convert isolation into seclusion. Secluded life is the life lived by our ancestors from the age of 75. 50 onwards, they were trained, and after 75, they lived a life of seclusion, and they were called sannyasinis. So, secluded life was loved by them. They could do higher practices in a secluded condition only. So, instead of isolating somebody or self-isolation, we should train people to live a secluded life. And introspection is possible only when you are aloof. And that aloof is not isolation. It is a secluded life. And that gives an understanding as to who you are. Thank you very much.
Thank you, Guruji, for the extensive advice for the holistic approach. I thank all the panel members for sharing their views. Over to Gopi.
Yeah, thank you everyone for enlightening us with so much of information. And it's time to close the session, and I request Dr. Aishwarya Radhakrishnan, Treasurer, OATN, to provide, I'm sorry, she's the Treasurer, to provide the final remarks.
Thank you, Gopi.
Yeah.
So, this was a great session, one of the sessions organized by OATN, and by far this has been my favorite session. And today's topic, geriatric role of optometrists in geriatric care, not just eye care, but geriatric care, was brought out very well by our speakers and panelists, I guess. The speakers provided excellent information, from Lisa talking about the role of vision in falls, and Dr. Srinivasa Marmula talking about his novel home screening approach and home eye care approach. And we heard a good talk from Dr. Gopal about the assistive devices and various other aspects of geriatric eye care and how vision is in general in age group. And the panel discussion was one of its kind. We had members from various facets who are currently working with geriatric people, and like one of the speakers said, we all can relate to the topic since we have people at home who are in that age group. So with that note, thank you to all the speakers. It was a great session. It was an eye-opening session, and we look forward to more such sessions from OATN and organizing people. Thank you.
Yeah, I request Ms. Maheshwari to provide the vote of thanks. Maheshwari, ma'am, are you there? Yeah.
Hi, good evening, everybody. This session was excellent, and we have been going through this session. It was excellent, and we have covered all ranges of geriatric optometry. So we have seen all the aspects from yoga to say from the research background in optometry, and we have seen that how to manage the falls, and it's not only the scientific aspect and also the holistic aspect. Thanks to all the people who have organized, and thanks for the audience, and thanks for the organizing team. Thank you.
Gopi, you have to unmute yourself.
I'm sorry. Yeah, I was not realizing it. So I request everyone to kindly provide your feedbacks. I will post the feedback form in the chat box. And with this, we close the session for the day.
And Gopi, you need to talk about this. You wanted to congratulate Dr. Lisa and Dr. Vijaya,
Yes,
right?
yeah. And I wish to congratulate Dr. Lisa and Dr. V.K. Gotwal for getting placed, like I would not say getting placed, because of their work, they are being ranked in the like top 200 research optometrists recently published from Clinical and Experimental Optometry 2021. And congratulations to both of them.
Yeah, and thanks to all the speakers for your for allocating time on a Sunday, especially, and for Dr. Lisa to join us despite this fight. It's almost like now 10:30 in the night for you. Yeah, so thanks to all of you once again. And any final words from any of you before we close the session? Oh, thank you. Thank you, Dr.
Thanks a lot. Thank you very much.
Yeah, thank you, Guruji.